Hi, thank you for having me here today. I have nothing to disclose, unfortunately. So, chronic mesenteric ischemia, it's a spectrum of circulatory disorders categorized by the acuity of the symptoms and the distribution of the disease. But for the purpose of this lecture today, we're going to concentrate on chronic arterial mesenteric ischemia and acute arterial mesenteric ischemia because these are the two entities they are called usually to treat as vascular surgeons interventionalists. So the incidental finding of mesenteric stenosis in the elderly population is quite common. However, the incidence of the symptomatic disease is very rare. It's 1 to 100,000. Usually affects patients that they are 50 or 60-year-old. It's one of the few atherosclerotic entities that's more common in women. Rarely gives symptoms, and if it is left untreated, the mortality and morbidity is very high. There's a wide range of causes, but the most common is atherosclerosis, and actually it's just plaque from the aorta that extends into the ostium and the first 2 centimeters of the vessel, and that's for the chronic mesenteric ischemia, as opposed to the acute mesenteric ischemia, which is due to an embolus that lodges somewhere close to the takeoff either of the middle colic or the ileocolic artery. The vessels that contribute to the perfusion of the intestine and thus are affected with mesenteric ischemia, it's the celiac artery with the main collateral to the SMA through the GDA of the hepatic artery, the SMA and the IMA, inferior mesenteric artery. Once there is a mesenteric ischemia, 2 main collaterals pathways can be developed. One is the meandering artery or arc of Riemann, and the other one is the marginal artery of Drummond at the inner edge of the colon. Symptoms include postprandial angina, cytophobia, weight loss, and many other non-specific GI symptoms. And the workup for diagnosis should include duplex, CT angiogram or MRA, abdominal ultrasound, and an extensive GI workup to exclude other entities that may cause the same symptoms. This is the duplex of a normal celiac artery. It's a low-resistance organ with high end-diastolic velocities and flow, and peak systolic more than 275 denotes critical stenosis. For SMA, there is diastolic flow only during the digestion and not during fasting, and peak systolic velocity more than 200 is also critical. The management, it's always, once you diagnose chronic mesenteric ischemia, it's always an intervention. And historically, it's open intervention, and that was some sort of bypass, anterograde or retrograde, aortomesenteric, iliomesenteric, to 1 or 2 vessel. This is a bypass from iliomesenteric from common iliac to SMA, the same bypass depicted with a CAT scan. And this is an aortomesenteric bypass from the supraceliac aorta to the hepatic and the SMA. The graft for the SMA goes behind the pancreas as shown in the slide below. Open reconstruction has durable results. However, it's associated with a mortality as high as 15% and morbidity nearing 70%, and it's not suitable for undernourished patients. And this is where the endovascular treatments are coming. The first one was attempted in 1980. The first treatments were only balloon angioplasty, so there was higher stenosis rate, but they had great 30-day mortality, around less than 4%. And at the beginning was bridged to surgical revascularization only. Percutaneous interventions can be accomplished through different access sites. There are different systems used, catheters and sheaths. However, I think the tour guide or any other steerable sheath can help us accomplish the procedure almost always through a transfemoral approach with the perfect angle to get into the vessel, and it diminishes the need for radial or brachial approach. Balloon expandable stents is the mainstay for the procedure. Cover stents are preferred. Pressure gradient measurements before and after the procedure are preferred just to determine the success of your procedure. Some people, they use IVOS, and antiplatelet treatment is debatable. I'll have to go quickly in these cases. This is a patient who had mesenteric ischemia. Seems that she had occluded celiac stent and her SMA. We went transbrachially. We crossed the stent with a V18 and a quick cross, and then we put a cover stent. This is the final result. This is another patient who had an EVAR 10 years ago and then had a renal stent and has this tight stenosis of the SMA. You can see it better here. It's between a chunk of calcium and suprarenal stent. Made the access of the SMA very difficult. We finally managed to go through with a steerable sheath and a floppy wire. It was difficult to displace the strut and accommodate the stent, and this is the final result. This patient presented with acute abdomen, had both celiac and SMA occluded, required exploratory laparotomy and bowel resection, and through an retrograde approach of the SMA, we did an angiogram. Here is the lesion. We balloon it and stent it. A week later, we went through the radial and we did a celiac stent, and this is the final picture. Retrograde mesenteric stenting has been supported by the literature with small studies. Seems to be a viable procedure for those patients that they need exploratory laparotomy. Obviously has high early mortality morbidity, but for those patients that they make it through the acute phase, the patency rate is good. And I want to now direct your attention to median arcuate ligament syndrome. This is when the celiac artery is constricted from the diaphragmatic crura. The pathognomonic sign is good flow through the celiac during the inspiration, no flow in high velocities during the expiration. It has this sling-like appearance at the angiogram. And for patients like this one, that they have MALS and they have a SMA stenosis and CMI, the right approach is to stent the SMA and not the celiac, because stenting the celiac without releasing the ligament leads to this fracture stent and occlusion. However, in those patients that they have SMA or celiac stent and they don't have MALS, the patency rate and the freedom from restenosis is similar. Literature supports, and there's emerging literature actually supporting the use of cover stents, not only for primary repair, but also for reintervention, with way better stents outcomes when you use cover stents versus bare stents. 1 year primary patency, it's 83 to 100%. 3-year patency, more than 75%, and secondary patency approaches 100%. The overall long-term survival for those patients is low, at around 50% in 5 years, like a bad cancer case. And for matched populations, the survival is the same for patients they receive endovascular procedure or open, and more importantly, the freedom of mesenteric-related deaths is the same. Finally, I want to close the presentation with presenting the clinical practice guidelines from our society. These were published in 2020. So patients with symptoms consistent with CMI should undergo extensive workup to exclude other potential causes. The primary target vessel should be the superior mesenteric artery. Endovascular revascularization with balloon expandable cover stent is the recommended initial treatment. Open repair should be reserved for younger patients and those that they cannot have endovascular procedures. Strict surveillance is must after revascularization, and those patients, they have recurrent symptoms after revascularization due to recurrent stenosis. They should again be treated with endovascular approach as the ones that have de novo lesion. Thank you.